Welcome to our YouTube channel of Trishla Foundation. This YouTube channel is related with the educational information for parents of children with cerebral palsy. Today we are going to talk about the crouch gait. Why the children with cerebral palsy walk with bending knee? There's many causes is there. Every parent should know everything about the etiology, why this bending of the knee occur in most of the children with diplegic and quadriplegic cerebral palsy. Crouch gait means the child walk with the bent knee. It is one of the most common gait pathology in cerebral palsy. Crouch gait is a part of natural history of spastic diplegia and quadriplegia. That means children where both lower limb are affected or all four limbs are affected. Crouch gait is in downward cycle mode if not intervenes. It means if surgical intervention here, whatever kind of intervention like fixed braces and other thing, you will know in this lecture, if it is not have been done and crouch gait is already occurred, this is going to progress with the age, height and weight. This walking posture needs 4 times higher quadriceps forces because child has to walk with bend knee, and with bend knee he has to bend more knee and they will be putting more pressure on the muscle anterior to the knee joint. You can see on this video that if there is knee flexion is more than 20 degree at initial contact and 15 degree throughout this transverse, then it will called as a crouch gait. There will be associated increased flexion at the ankle and hip joint also. There is, as I have told you, that crouch gait have many pathology and every pathology should be ruled out. This bending of the knee occur because of many reasons. You can see the list. You can see on this screen that first of most important cause was given that poor motor control and sensory issues from the brain side. And one side I have written the psoas contracture, that is psoas muscle at the hip joint, high patella, that is kneecap, high kneecap availability, and weak muscle anterior to the knee joint, that is the quadriceps. Flexion deformity at the knee joint, insufficient knee extension acceleration. Along with that, tibia is externally rotated, foot has gone outside, there is a plantar valgus split. Soleus muscle which is present in the second muscle in the calf, that is over lengthened. Excessive knee flexion acceleration, hamstring shortening, internal femoral torsion and weak gluteal maximus at the hip joint. All these are causes are precipitating the crouch gait. So every children will not have the every cause. They can have 1 or 2 causes that has to be managed and other causes has to be ruled out. How we can decide that which part of the problem is require management? That is the clinical decision making. It depends on diagnostic matrix. It can be decided by taking the detailed clinical history, how he walked, what were the precipitating events, how progress from the childhood, and in the physical examination, we can check the problem in the each and every level of the joint, hip joint, knee joint, and ankle joint, and that should be confirmed in the video gait analysis. In the video gait analysis, we have to check it from front, side, back, and where it is the problem, we can know much better with the combination of the physical exam and video gait analysis. That will be supported by the radiology and exam under anesthesia. And exam under anesthesia just before operation is very important to have the good decision and that will not go against the child. History. In history, we have to take birth history, age, developmental milestone, what kind of braces the child is using, what kind of surgical and physio intervention earlier they have undergone, progression of the deformity, functional capability of child, ambulatory capability and walking gait. And every this part of the history is very important in decision making, which child is require surgery, which will require the braces. As you can see the screen, this gross motor function classification system, level 1 to 5, and level 1 to 3 is known as the walking children, walker, and 4 and 5 is non-walker. And most of the crouch gait is progress in the level 3 or level 4. 5 is already on the wheelchair, they may not require any surgical intervention. But very important to prevent deterioration in level 3 and level 4. You can see on this graph also that every child, mostly GMC 3 and 4 or 5, they are going to deteriorate after the puberty, mostly at 15 to 16 years, and they require to progressively deteriorate if intervention has not been done and there is no continuous exercises that physiotherapy was being done. So it is very important to prevent this deterioration, but this is natural progression also that we cannot prevent. And as you know, the perceived cause of the gait decline is many factors that can happen. Worsening balance, pain in any joint, increased spasticity, loss of muscle strain, contracture, fatigue, fall, fear and falling, and loss of fitness. All those factors has to be taken before considering any intervention in the children. In the physical examination, we have to check from foot to ankle joint to tibial torsion, the knee joint, patella height, hamstring length, posterior knee capsule contracture, femoral torsion and hip joint also. In the hamstring length, hamstring means there is the muscle which is found behind the thigh. That is sometimes it is a contracted, shortened, but it can be checked better under the bilateral popliteal angle for the orthopedic surgeon. And we have to check this flexion deformity during the walk. It happened due to the hamstring contracture or posterior knee capsule contracture because of persistent for the long duration. That should be checked. That can be checked when child is lying down. In this video, you can see these 3 video. We have to check where is the problem, and video gait analysis is very important. That should check from the front, side, back, and where knee should be exposed. We have to check hip, knee and foot. What was the problem? We can determine, and that can be confirmed under the anesthesia. And ultimately, radiodiagnosis by taking the X-ray of the foot. In the foot, we can check this foot is going outside or it is a normal. And patellar height measurement is also very important in the management of the crouch gait. And X-ray pelvis we have to check hip migration percentage, because hip subluxation and dislocation are very common in GMCS 4 and 5 children. Even GMCS 3 you can get nearly 30 to 40% children who can have the hip subluxation. So before going for any surgical intervention, X-ray of the hip and pelvis is very important. First of all, we should always like to know how we can prevent this crouch gait. We cannot prevent totally, but we can prevent up to some extent by some measure. Just as you know that most of the time earlier 15-20 years back, whenever we see the child is walking in the toe walking, then most of the surgeon goes for the tendo-Achilles lengthening, surgical lengthening of the heel cord. And even nowadays also only few surgeons will operate. That heel cord lengthening will also lengthen the soleus muscle. As you know that 1 centimeter of the soleus muscle lengthening can cause 50% decrease in the muscle power. Exertion will be decreased. So for the crouch gait, that is TL lengthening is very important cause, so that soleus lengthening and TL lengthening should not be done in most of the children as much as possible. If required, then gastrocnemius surgery, not the tendo-Achilles lengthening. And when the child start walking with the bent knee, then child should be prescribed with solid F4 or FRO. Early intervention should be done to prevent progression. Strength training of the anti-gravity muscle, including the quadriceps, hip extensor muscle, soleus muscle, and stretching of this muscle should not be done. Treatment is based on age of the child, remaining period of the growth, GMCS level, etiology and associated problem. If child is very young, less than 6 years age, but it is rarely manifest at this age. If they really manifest because of the weak soleus, vesti and gluteus, they can have the poor motor control. The child can have the planovalgus fit, obese child, there can be the hamstring tightness, but at this age we have to manage it conservatively. Surgical decline should be given to the child and surgery should be deferred till the age of 7 to 8 years, till the maturity of gait pattern when this can happen at the 7 to 8 year age. Now we'd like to know, if depending on the etiology, what kind of intervention we require. If the child have poor motor control along with weak muscle, just like the anti-gravity muscle, weak quadriceps, weak soleus, hamstring, weak gluteus maximus, then they require the physical therapy. In the physical therapy, stretching exercises should not be done. They require strength training, pelvic control exercises, training of weak gluteal maximus, vesti, that means quadriceps, soleus muscle. And sometimes if there is tight hamstring is there, then stretching is required. And these early children should be protected by giving the fixed AFO, limited range of AFOs, leaf spring AFO or FRO. And in this age also, if you use the stretching orthosis as shown in the figure, that can prevent further progression of the flexion deformity at the knee joint. It will stretch out the posterior knee capsule. It can be very helpful between 6 to 10 years. Earlier, we used to give the botulinum toxin and plaster application, but now we rarely use botulinum toxin. But as plaster and wedge correction is very helpful to correct this spasticity, and somehow up to some extent there is contracture of the hamstring muscle that can be used. In rare cases, we now also use the botulinum toxin, but very rarely. In this slide, you can see this one child who is walking with the jump knee gait. This knee was flexed. After giving the botulinum toxin, plaster and FRO, he is able to walk straight without any knee bending. Now come to the older kids. After the age of the 7 to 8 years, it is multi-factor involvement. Intervention is based on specific finding. The most of the time, these children require single event multi-level corrections. That means whatever kind of problem is there, that has to be managed in single event anesthesia. And all the deformity will be managed in the single setting. It's not true that only one time surgery will required in the lifetime of the children with cerebral palsy, one at the 7 to 8 year, and he may again require after the puberty at the age of 14 to 16 year. Now come to there is etiology, what kind of the problem in the older age children. If there is no fixed deformity, there is liver arc problem, then braces and intensive therapy is required. They also require balance training, strengthening exercises. In the brace, they require solid FO and FRO. In the planovalgus fit, if age is less than 7 years age, then we give molded FO because foot is not matured. And after 7 years, they may require surgical intervention. But the planovalgus means foot is going outside. That has to be corrected, because if foot is going outside, soleus muscle will not able to work. And function of the soleus muscle is to straighten the knee joint, so that the foot should be straight. For straightening of the foot, if there is mild deformity is there, light problem is there, that lateral calcaneum lengthening, that means lengthening of the heel bone, that's not a calcaneum bone. If it is more than normal, moderate deformity, then we also need the medial reefing of the talonavicular joint. Talus and navicular bone joint will be the reefing, and sometimes we put the screw also. If more than this deformity, moderate to severe deformity, we can have to fuse between the talus and calcaneum. If his patient is the adult, he crosses the maturity, then he may require fusion of the all posterior joint, including the subtalar, talonavicular, calcaneocuboid, that known as a triple orthosis. And now come to the external tibial torsion. External tibial torsion means whenever child is standing, foot is going outside, and that foot is going outside, it is because of leg bone which is rotated outside from the distal portion. That means this muscle will not work properly, so that they have to walk in the crouch curve. So they require surgical intervention to correct that deformity, and the surgical intervention will need cutting of the bone distally in the tibia, and derotated internally, and that will be fixed with the plating. That is one example here I have given here. He was walking with the crouch gait. This 10-year boy, he has bilateral external tibial torsion, bilateral plantar valgus feet, hallux valgus, short hamstring, and all the deformity was corrected. You can see that now he is able to walk straight without bending of the knee. That he has undergone surgery in the back of the knee, that is semitendinosis hamstring lengthening, calcaneum heel bone lengthening also there, bilateral distal rotational osteotomy of the tibia, and grade 2 corrections. Now come to the over lengthened tendinochalalis. Sometime this child has undergone surgery already before coming to us. In that cases, most of the time the heel cord is lengthened. As I already have mentioned, that heel cord lengthening lead 1.2 centimeter lengthening lead to the 50% reduction in the power. So we cannot do anything in that cases. But whatever we can give only fixed braces, so that again he should not bend forward. Now come to the femoral torsion. Femoral torsion means thigh bone. Femur is internally rotated because there is problem in the proximal upper part of the femur, where the neck has gone outside more than the required. So that we require proximal osteotomy near the hip joint or near the knee joint, depending upon the requirement. Where other pathology is there, if there is no pathology in the hip joint, we will do the surgery near the knee joint. If there is some pathology at the hip joint also, we will manage the hip joint pathology and derotation in the proximal part of the femur. This one example is there, where the girl have one side femoral internal torsion and bilateral external tibial torsion was there. This known as torsional malalignment syndrome. She has undergone osteotomy of the distal femur and osteotomy of the both distal tibia. After doing only this osteotomy, knee is corrected. Now she is able to walk straight without any deformity at the knee joint. Now, after this very important part of the crouch gait, that is hamstring. As we know, by literature we have seen that hamstring is not always shortened. Earlier, before 2 decades, always when we see the child in the crouch gait, we always think that hamstring will be shortened. But now after gait analysis, gait lab reports, we have seen that hamstring may not be longer in place of shortening. Lateral hamstring muscle, that is the bicep femoris, should always be spared during the surgeries. And whenever we require the hamstring lengthening by checking the bilateral popliteal angle, we have to release only by the myofascial release. It is better than the functional lengthening. And other kind of surgery is the transfer. As you know, if you are lengthening the hamstring muscle, that is the back muscle of the thigh, that is known hamstring, then this hamstring muscle is the flexor of the knee joint, but it also act on the hip joint as the extension. So if you are lengthening the hamstring muscle, the patient will have the anterior pelvic tilt. That should be prevented. And other problem can happen, genorecurvatum, that means knee is going backside. And both this problem is very painful for the child and adult, because in the long term he can have increased lumbar lordosis, he can have the pain in the lumbar spine as well as the knee joint. So that should be prevented. So in place of the lengthening, in most of the time we do the hamstring transfer. In the hamstring transfer, we transfer this one of the muscle only, semitendinosis, where distal part of the femur at the adductor magnus muscle insertion. And if there is really shortened, other muscle is shortened, then we will release only the myofascial release of the semimembranosis. By that transfer, the hip power is remain there. There will no pelvic tilts, knee flexion deformities disappear, and child will have the good recovery. As you can see in this video, this girl who have the very tight knee joint because of the hamstring contracture, shortening, she has undergone transfer, release of the adductor longus at the hip joint, and now she is perfectly normal, walking with the straight knee. After this hamstring muscle, other problem of the crouch gait is the flexion deformity. a knee is not straightened at all whenever she or he is lie down supine. That happen because of posterior knee capsule contracture. But we need to differentiate between the muscular and posterior joint contracture. As you know, this more than flexion might be indicator for more urgent intervention. If will be more than 20-degree flexion contracture, they are going to progress very fast. That should be prevented. And depending upon the joint capsule contracture, if there is less than 10-degree contracture is there only, we will, and if there is hamstring shortening is there, then we will do the hamstring shortening along with the plaster application and wedge correction. If 10 to 20 degree is there, an adolescent girl or boy is there, 10 to 13 year, 14 year age, then we will give growth modulation of distal femur by applying 2 screws in anterior part of the distal femoral growth plate, so that by increasing the age, the posterior part of the growth plate will increase, by that deformity will subside in coming years. But if there is more than 20 degree deformity is adolescent and any degree of fixed flexion deformity adult, then they require distal femoral extension osteotomy. You can see this few x-rays of growth modulation where we have put it in one child we have put it the plate anteriorly, but because the plate had the lots of problem because irritation to the synovium capsule that will lead to the pain and stiffness, we start giving the screw in anterior part of the distal femur. There is no problem, child can start walking within a day. There will not be there will be no hindrance in the rehabilitation also. He can go for exercise on the second day, and with increase in the age, the deformity will decrease and that will correct. The one case here I have shown that 10-year female, very spastic hamstring was there, crouch gait, which is 4, bilateral short hamstring was there, bilateral external tibial torsion. This was operated 8 years back, and now in that summer we were not doing any growth modulation. Growth modulation we started doing since 2 years only. In that cases we have done bilateral semi-tenuous jet lengthening, bilateral semi-tenuous 5 vessel release, plaster wedge correction, braces and therapy. Now she is able to walk straight with 2 sticks, and now we are planning to do distal rotation, distal tibia and bilateral tibial tuberosity distal transfer to prevent the future problem in adults. Now the last operation, that is distal femoral extension osteotomy. This procedure is usually being done if deformity is very severe in adulthood. But along with that, most of the time we do patella tendon shortening or advancement by the tibial tuberosity. That both have very good impact on the child. Why we do the patella tendon shortening or patella distal transfer? Because in most of the crouched gait, because child is walking in the crouched gait, bend knee, most of the time this anterior kneecap go upward and patella tendon is stretched down. Because of that stretching, patella sometimes fracture at the distal third, and this high position of the patella is known as patella alta. In that cases, we have to take this patella alta to downward to prevent the anterior knee pain, to prevent the extensor lag and lots of other problems which happen because of this problem. This can be done by the shortening of the patellar tendons or cutting an advancement of the patellar tendon, or sometimes just cutting the bone where patellar tendon is attached. That means distal transfer of tibial tuberosity. But distal transfer of tibial tuberosity can only be done in the adults, and patellar tendon shortening and patellar tendon advancement can be done in any age groups, even in adolescent where growth is not completed. In that shortening, most of the time you prefer the proximal to distal half overlap, but different methods are available depending on the requirement, their expertise. Most of the surgeons will do different ways of the patellar tendon shortening. In adult, we cut the tibial tuberosity, transfer distally, and by that we have taken the patella to distal downward. By that external lag will not be there and child can start walking straight. In this case, we can see that 15-year female With GFCS 3, there was left planar valgus fit was there, fixed flexor deformity both sides. She is already matured adult. So she has undergone bilateral extension osteotomy of distal femur. That deformity was corrected. And there is distal tuberosity of tibial tuberosity was also done. And now plate and screw was removed. Now she can walk straight without any bending at the knee joint. That is excellent improvement. Another child, 19-year male, that's not child, is adult. He was with very severe dystonia and very severe deformity at the both knee joint, mixed diplegic cerebral palsy. And GFCS 4 was there. He also undergone bilateral distal femur extension shortening osteotomy, abductor tenotomy, bilateral patella tendon shortening. After that, he had also had few medicine to control the dystonia, and he has undergone 6-month intensive therapy. Now he is able to maintain his body weight, he is able to maintain the alignments, he is able to walk straight without any support, only with the stick, walker, elbow crutches, even with the walker. That is excellent improvement in this child. Last cause was the post-psoas muscle shortening. Psoas muscle is rarely causes this crouch gait and rarely require lengthening. But if really this problem is there, then we have to do intrapelvic intramuscular tenotomy in ambulatory child. In very important example, I can show you this. You can see the video that this girl was quadriplegic, spastic CP. She was inside the home because that there was severe vitamin D deficient was there. She walked in the crouch gait. GFCS 4 was there. A severe flexion deformity in the hip and knee. She undergone surgery after the sufficient vitamin D supplement. In the surgery, hamstring lengthening was done, tibial central lengthening was done, tibia derotation osteotomy was also done, and psoas muscle was lengthening done, and 2-time plaster application and wedge correction. This girl also was operated 6 years back. Now she is completely independent and walking, and her spine is also straight. Earlier, the severe kyphosis was there. So, in the last, I will tell you, there is this crouch gait and the very long-term bad impact on these children. This crouch gait has to be managed to have the good ambulatory capability even in the adulthood. What are the long-term consequences? This crouch gait increases the quadricep demand that can lead to the high patella, that lead to the stress fracture of the patella distal third. And if persistent for the long duration, that will cause painful joint degeneration, just like the osteoarthritis in old age. This also causes increased energy cost of the walking, because he is walking with the bent knee. He has to expend lots of energy in walking, and there will be loss of independent gait in long term. So, finally, I want to say that crouch gait is the natural phenomena in the life of cerebral palsy children, especially diplegic and quadriplegics. It is progressive unless intervenes. So, it has to be managed, but prevention is always better than the cure. For prevention, we have to use proper bracing, no tendoculus lengthening, no heel cord lengthening, weight should be controlled, proper bracing should be there, and we should avoid muscle tendon surgeries most of the patient. If you wanted to know much more about the crouch gait, lots of video we have uploaded at our YouTube channel of Trishla Foundation. We have play group of this playlist of these videos that is available up. I have also given the link there. You can go there and have look on those videos. And Hindi version of the educational talk in the crouch gait, that is bent with knee, मैंने cerebral palsy बच्चों में घुटने मोड़कर चलने पर शैक्षिक वार्ता का जो हिंदी संग करा रहा है, वो YouTube लिंक भी यहाँ पे दिया है, उस प्लेलिस्ट में भी दिया है. जिनको देखना है वो जाकर के उसमें जाकर के पूरे सुन सकते हैं. और इन चीजों को फॉलो करते रहेंगे आप, तो बहुत सारी जो बच्चों की आने वाली समस्या है उनको हम रोक सकते हैं. और बच्चों में पूरी जानकारी हर अभिभावक को होना जरूरी है. दैट्स वेरी इंपॉर्टेंट टू हैव द कंप्लीट इंफॉर्मेशन on all aspects of cerebral palsy for all those parents who have these children. And crouch gait is very bad if not managed properly. Child whose walker can become non-walker, completely wheelchair bound in long term. If you want more information about cerebral palsy, log to our YouTube channel, Trishla Foundation. We have uploaded lots of video. A regular period, we are uploading one video every week. So, be with us. Know all the information with cerebral palsy on this video. If you have a query, just put all those messages on the comment box. We will try to reply it. And if you like this video, subscribe our YouTube channel of Trishla Foundation.